In this series of videos, we're going to focus on lower gastrointestinal pathology. We're going to start with the small and large intestine correlations with Chinese medicine, biomedicine. Going to look at constipation, diarrhea, malabsorption, celiac disease, and IBS in our first video, and then we'll look at inflammatory bowel diseases, colon cancer, etc. in subsequent videos. So I think these correlative patterns should be fairly obvious to you by now, but again, looking at what we might call small intestine yang, this really refers to the arterial blood flow metabolism, and that would relate to the ability of the small intestine to receive enough oxygenation, to have proper function of the brush border enzymes as part of the final process of carbohydrate and protein digestion. So small intestine yang deficiency would be lack of those brush border enzymes, decreased catabolic activity, and maybe decreased immune activity. Versus a small intestine heat or fire picture would be more inflammation, increased catabolism, and we might see that in like Crohn's or celiac disease, where we get actual loss of mucosa and malabsorption. The qi deficiency would relate more to autonomic nerve problems. So in the qi deficiency, we'd see more lack of enzymes, but also lack of peristalsis, more bloating, and the lack of peristalsis might lead to small intestinal bacterial overgrowth, or SIBO. So that might be more prevalent in irritable bowel syndrome that has constipation is a predominant type, versus the qi constriction pattern would be basically more cramping, and that would be something you'd see more in IBS-D, the diarrhea subtype. Now, IBS is not just a small intestine, we also consider that a large intestine disorder, so it kind of covers both. Small intestine blood would be the nutrition, the hormones, and the stimulus to the wall, so things like secretin, cholecystokinin, motilin, GIP, we've talked about a lot of those already in the physiology section. So blood deficiency might result in decreased activity and function, and excess we might think of as actually hemorrhage. There is a blood stasis pattern. One can get infarcts in the mesenteric artery system, and that can lead to ischemia and even infarction in the in part of the bowel wall. And then yin deficiency would be, or yin, sorry, would be the mucosal barrier with the microbiome. And so a small intestine yin deficiency, less mucus versus an excess would be increased, and we'd see SIBO in the small intestine, dysbiosis in the large intestine. Same thing, I'll just put that chart there for the large intestine, same kind of thinking applies. So we can start to think about the different small and large intestine disorders from this context. Now, one of the ways that small and large intestine disorders manifest is through changes of stool, and our polarities there will be constipation and diarrhea. So let's look at constipation here first. So this is a symptom, not a disease. There's many underlying causes to constipation, so we always have to dig deeper. It's defined as 3 or fewer bowel movements a week that are difficult to pass, and it's one of the most common GI complaints in the US. If you put dyspepsia in there, functional dyspepsia, then we have, like 90% of the complaints that people have going in, digestive complaints going into primary care. The causes, there are many. Early on constipation that develops very early in life, we usually start thinking about congenital causes. So one to be familiar with is something called Hirschsprung disease. In Hirschsprung's, the enteric nervous system does not develop in the lower colon. So basically there's complete dysmotility. And unfortunately for Hirschsprung's, the real solution is surgical. It's actually resection of that portion of the bowel so that the normal bowel portions can be restored. But that's not going to be typical, especially for constipation in later life. So we divide those types of constipation into primary and secondary. In primary constipation, we can also call that functional constipation. It's the most common form. It's a problem really of the large intestine. There's no other medical conditions, medications, etc. that are triggering it. And we generally have 3 types of primary constipation. What's called normal transit constipation. That's the most common, and it's often associated with irritable bowel syndrome, the constipation type. Slow transit, so normal transit, the peristalsis is still functioning fine, but the defecation reflex just is not triggered adequately. In slow transit constipation, there's infrequent bowel movements, decreased urgency and straining, more common in females, and there's actually impaired colonic motor activity. So it's a problem of the enteric nervous system in the large intestine. Pelvic floor dysfunction would be lack of anal sphincter tone, and there'd be prolonged straining. People sometimes have to use digital evacuation to treat that. Secondary constipation, which is something we should always look for in the history, looking at constipation, would be number one, medications. Opioids and NSAIDs are well known to trigger constipation, opioids in particular. Endocrine problems like type 2 diabetes, hypothyroidism. In pregnancy, we see constipation. Also problems with electrolytes, low potassium, magnesium, and high calcium. Neurological issues after stroke, Parkinson's disease, highly correlated with constipation, probably from loss of dopamine in the bowel wall, and that is, again, needed like serotonin to stimulate the colonic contractions. MS, and then neuropathy that develops in the autonomic nervous system from chronic type 2 diabetes, peripheral neuropathy. Celiac disease, connective tissue disorders like scleroderma, amyloidosis, lead poisoning, not common, but that can cause chronic constipation. In fact, there is a homeopathic remedy, homeopathic lead, plumbum, which is used for very hard, dry, infrequent stools. And then liver kidney disease can manifest as constipation. The bile needs to be adequately secreted. Bile actually acts as a stimulant for the peristalsis in the intestines, both small and large intestines. So if there's inadequate bile flow, that can lead to poor peristalsis, poor transit. Any sort of structural damages like strictures or sphincter damage that can happen, for example, in chronic Crohn's disease. In Crohn's, there often is strictures of the intestine chronically. Cystic fibrosis, where there's too much, it's a genetic problem of a chloride transporter, and that can result in very thick, abundant mucus and delayed peristalsis. Also, psychosocial, depression, anxiety, somatization disorders are all correlated with constipation to various degrees, and that's partly because, like with depression, we do know that serotonin is one of the neurotransmitters involved with depression, and serotonin, remember, is a major neurotransmitter in the enteric nervous system. And then colon cancer also can be a cause of constipation. So we kind of rule all these out when working up person diagnosis for constipation. The clinical presentation, really, there is something called the Rome 4 criteria, and that is actually what we use to quantify and actually determine a diagnosis of constipation, and that is having at least 2 of the following over the past 6 months. So less than 3 spontaneous bowel movements a week, straining for more than 25% of all defecation attempts, sensation of anal rectal obstruction for greater than 25% of attempts, sensation of incomplete evacuation for greater than 25%, and manual maneuvering to defecate like digital evacuation for over a quarter of the attempts. So again, 2 out of those 6, that according to the guidelines and the Rome 4 criteria, meets the criteria for constipation. Patient must rarely have loose stools without using laxatives, and doesn't meet the Rome 4 criteria for IBS. So a lot of people have IBS with constipation, and that's one of the subtypes of IBS we'll see. There's actually several IBS subtypes, but one has more constipation predominant. But with IBS, there's always abdominal pain and so forth, and we'll look at the Rome 4 criteria for that. So sometimes they can be mixed, but just straight constipation shouldn't have the abdominal pain. That's going to be something characteristic of IBS. We often use the Bristol Stool Chart to help a patient kind of tell us about their stools, and we basically have little things printed out for them. Basically, in severe constipation, the stool is often what we call Bristol Stool 1. It's rabbit pellet-like, versus the other end would be Bristol Stool 7, severe diarrhea. Ideal would be Bristol 3 and 4, which is more the sausage type in between. So this can be helpful for helping having a patient kind of tell us where they're at in terms of their bowel form and consistency. Patients will often complain of abdominal bloating, hard dry stool, pain on defecation, rectal bleeding, spurious diarrhea, low back pain, and feeling of incomplete evacuation. Now, our red flags here for constipation, which would maybe increase our suspicion of things like colorectal cancer and so forth, would be any of the hematochezia. Remember, that's blood, frank blood that we see in the stool, or melena, that's the darker stool. Unintentional weight loss, person's not trying to restrict calories, they're going on a diet and they still keep losing weight. Significant abdominal pain, inability to pass flatus, and that might indicate an obstruction. Change in the stool caliber suddenly, so it starts getting much narrower than before. That indicates stricture or obstruction. Nausea, vomiting, fever, and then back pain was what's called saddle anesthesia. That can happen with spinal cord injuries, where people get numbness, loss of bladder and bowel control, and in their lower body, and that indicates a prompt referral to have that investigated. So these are some of the red flags to think about for constipation. Now, the complications of constipation are, a lot of people, especially with the primary constipations, will take laxatives, and there is habituation phenomena. So if we look at the treatments, I'm not going to discuss those in depth here, but really there's several approaches to constipation. One is to use fiber, and that would be psyllium and so forth. And we're talking about primary constipation here. Number two would be to use the what are called osmotic laxatives. And osmotic laxatives would be things like magnesium or Miralax, the polyethylene glycol. These basically pull water out of the intestine. So they pull water out of the intestinal wall. That creates more lubrication, more fluid in the intestine, and that helps people pass stool. And the third layer would be the stimulant laxatives. And these stimulant laxatives all contain compounds called anthraquinones. And so that would be things like senna, but that's also in rhubarb, Cascaris sagrada, a lot of these other herbs all have anthraquinones. And the problem with anthraquinones in particular is that they can create habituation. People keep taking them, and they lose their function over time. Another interesting thing is that anthraquinones are dyes. They're actually used in the dye industry, and they can dye the inside of the intestine black, and that's called melanosis coli. We don't think that's cancerous or precancerous, but when a gastroenterologist goes up with a scope, they might see the whole inside wall of the intestine looks black. That's called melanosis coli. So these are our three big classes, and the further you get down this list, the more habituation occurs. Usually you don't become habituated to fiber, but these other ones might be a possibility. I usually start at the top of the list and work down for primary constipation. Again, trying to look at other issues like the whole endocrine tree. Is there any problems with the adrenals or thyroid or sex hormones that might be contributing to the constipation? Hemorrhoids can result from chronic constipation, anal fissures, pelvic floor damage, rectal prolapse, rectal ulcers, and what's called megacolon, where the fecal impaction is so bad the colon swells to a very, very large size, and that can create a bowel obstruction, and that needs emergency evacuation, sometimes even surgery for that. So the assessment for chronic constipation is determined, first of all, is this acute or chronic constipation? Rule out the red flags, rule out congenital and secondary causes, and then refer for imaging if needed, like a colonoscopy, CT scan, etc. So that's just a little bit on how to think about constipation from the biomedical angle. Now, diarrhea is at the other end, and this is a reversal of normal net absorptive status of water and electrolyte absorption to secretion. So basically, you end up secreting things from the bowel wall, and it's not all absorbed, so it ends up passing in the stool. The clinical presentation, again, this can be acute or chronic. It's going to be more pronounced in acute diarrhea, but frequent stools, dehydration might be there. So I'm always for acute diarrhea like gastroenteritis, traveler's diarrhea, looking for, is there lethargy, depressed consciousness, that might indicate severe dehydration. Sunken anterior fontanelles, that would be in the children, you'd see that. But dry mucous membranes, sunken eyes, lack of tears, poor skin turgor, so you pull up on the skin on the back of the hand, for example, and it doesn't really stick up, there's not a lot of moisture there. And then delayed capillary refill. These would all be kind of red flags for severe dehydration. Abdominal pain, cramping, lots of the borborygmi, which is the sounds of the intestinal churning that we can hear with the stethoscope, and then perianal erythema, just from frequent, passage of stool. Red flags here would be, again, hematochezia. That might indicate for acute diarrhea, dysentery. Fever is going to suggest an infectious cause again. Unintentional weight loss over 5 pounds, significant abdominal pain. Family history of colon cancer, IBD, celiac, age over 50 with a change, like a new onset of symptoms, and severe dehydration. So those would all be things to look out for. For acute diarrhea, this is abrupt onset of 3 or more loose stools a day for less than 2 weeks. We want to really look at the history, a travel history, and possible exposure. Did they go stay on the farm? Did they go camping? Things like that. And our typical causes would be infectious, and we can divide that into bloody and watery diarrhea. So bloody diarrhea would be the classic Salmonella, Shigella, Campylobacter. These are bacteria. And enterohemorrhagic E. coli, as well as enteroinvasive E. coli. Entamoeba histolytica, which is a parasite. It's an amoeba, and that can create liver abscesses. Clostridium difficile, this one's associated with what's called pseudomembranous colitis. If you look in the large intestine, it forms like this biofilm over the inside of the lumen of the intestine. This one is associated with, remember, the PPIs. People are at higher risk for developing C. diff, as well as antibiotic use. That's why, you really want to be careful about antibiotic overprescribing, because this is one of the risks, and this can create very bad bloody diarrhea over time. And then Yersinia enterocolitica. Yersinia pestis is actually bubonic plague, and this is another species of Yersinia. Watery diarrhea is going to be cholera, which we don't see unless it's in a cholera endemic area, but this can be fatal from just severe dehydration. Giardia typically creates watery, non-bloody, foul-smelling, greasy stools. Cryptosporidium, this is going to be typical in immunocompromised patients like with HIV, full-blown AIDS. Enterotoxigenic E. coli, and then different viruses. Rotavirus, very common with travelers. Same with Norwalk virus, and then even the cold viruses. See this one a lot. People after airplane travel might get watery diarrhea, and that's typically a rotavirus. Can also be acute diarrhea post-surgical. So those are the typical causes of acute diarrhea. The assessment we would typically do, the thing about a lot of these intestinal infections is they're pretty self-limited, and so we really, the only thing to do is to provide hydration. And so we're going to do what's called oral hydration therapy. In fact, intravenous hydration is not needed for most of these. You want to do oral hydration and even give so with hydration you want to give the electrolytes as well. And if you go online, you can find the World Health Organization, WHO, oral rehydration guidelines, and they tell you how to mix up a very basic rehydration mixture with different electrolytes. You can also purchase those. But we might want to check for different parasites, and that would be the oven parasite testing ×3. The CBC would tell us, if in this case not about anemia, but about your white blood cells if they're elevated. A CMP might look for if you're having severe dehydration. You can get what's called an anion gap. We'll talk about that later in the kidney section. And then we can do stool cultures for specific agents if necessary. Again, for the majority of these, we don't culture really or look for them. We just support the body as the immune system kind of does the work to clean up. In fact, most of these, like the bacterial ones, we don't want to give antibiotics in the early phases because you actually want your immune system to kind of take care of it. Antimicrobial therapy then is only going to be as needed. Usually antidiarrheal agents are contraindicated. A lot of people will take like over-the-counter things, loperamide, things like that, antidiarrheals for acute diarrhea, which is not a good idea because that your body's trying to get rid of whatever bacteria, and a lot of these bacteria, either their cell walls are acting as what are called endotoxins, or they're secreting exotoxins, and you want that all to flush out. You don't want to keep it in. So that's the typical approach to acute diarrhea. Chronic is anything over 2 weeks, and lots of causes, so I won't go through all those, but the most common things would be what's just called functional diarrhea. That's often associated with IBS-D, IBS diarrhea subtype. Inflammatory bowel disease like ulcerative colitis, that's a common one. That's going to have bloody stools. Crohn's can have that as well. Celiac disease, lactose intolerance, these can have chronic diarrhea from malabsorption. All those nutrients pass through you and they act as osmotic agents. They pull water out from the intestinal wall, just like the osmotic laxatives, and you get diarrhea. In fact, in lactose intolerance, it can create life-threatening dehydration in severe cases. Lots of medications, laxatives, caffeine, alcohol. Hyperthyroidism and type 2 diabetes can cause chronic constipation. And then cancers, and then a lot of cases are just idiopathic. We're not sure why a person has this from a biomedical angle. Assessment would be, again, standard history, physical exam, abdominal exam, the appropriate labs, especially looking at your, see if there's any infection, but looking at the CMP for electrolyte problems. Are you getting low in particularly potassium is lost in the diarrhea, and people can get severe hypokalemia as a result of that. And then any relevant imaging that's necessary. And the treatment really is to address the underlying cause, whatever one of these is going on. So that's the approach to diarrhea, both acute and chronic. So related to diarrhea would be the malabsorption syndromes. And this is really defective absorption of fats, fat-soluble vitamins, proteins, carbohydrates, electrolytes, minerals, and water. And usually malabsorption begins, remember, it's your jejunum that does most of your absorption of nutrients. So it's with small intestine disorders. Interestingly, a lot of large intestine disorders like ulcerative colitis and so forth don't result in major malabsorption except for water and maybe some electrolytes if there's chronic diarrhea. But the small intestine disorders definitely, like celiac and Crohn's disease, can result in malabsorption. The most common presentation is going to be chronic diarrhea, and specifically steatorrhea, which is where you see there's excess fecal fat. So a couple characteristics of steatorrhea: the stool looks paler, and that indicates lack of bilirubin. Bilirubin is one of the constituents of bile, and gives the coloring. When the intestinal bacteria metabolize it, it turns it into a darker compound, and that's what gives your stools their color. So if you're not secreting enough bile, then you're going to have the lighter stools. You also can have the fat, remember, requires, pancreatic lipase. It needs bile acids to be absorbed to form into those micelles. But it also needs an appropriate brush border, and it needs appropriate enterocytes. So if there's loss of those enterocytes from inflammation, like in Crohn's or celiac, in fact, in celiac, a classic thing we see is flattening of all the villi. So the villi disappear, basically. And all the fat's going to go through you, and that is going to float on the surface of the toilet. It's going to look greasy. And again, the stool might look yellow, especially if there's lack of bile. And that would typically be from the liver gallbladder not producing enough, or maybe gallstones blocking it. Weight loss would be another classic finding of chronic malabsorption. And most particularly, we'd see malabsorption of different vitamins, but in particular, the fat-soluble vitamins A, D, E, and K. So it can result from a defect of at least one of the following, and that's intraluminal digestion. So lack of any of the digestive enzymes from the pancreas, stomach acid, or bile, as I just mentioned. So that can be from pancreatic insufficiency, decreased bile flow, or hypochlorhydria. That's one. Number two would be terminal digestion. That's at the brush border. And so any loss of brush border due to atrophy of enterocytes or genetic problems like a lactase deficiency, creating lactose intolerance, that's going to create malabsorption. Again, with lactose intolerance, it can be very severe with a lot of intestinal inflammation, we get bacterial overgrowth, and then chronic diarrhea, which can be very dehydrating. And then lack of transepithelial transport. So that's the failure of the fluid and electrolytes to be transported in the small intestine epithelium. And so problems, again, loss of enterocytes from the chronic inflammatory conditions. So the causes could be, again, digestive defects like pancreatic insufficiency, pancreatitis, disaccharide deficiency like the lactase deficiency, and then problems of the lipoprotein formation. So there are some genetic conditions that result in that, and then you'd have decreased fat absorption, and you would have more steatorrhea. Infections can actually cause malabsorption. There's something called tropical sprue. It's caused by, at this point, an unknown tropical bacteria. And then Whipple disease, caused by a bacteria. So these are identifiable. These are potentially treatable with antibiotics. Post-surgical complications, but probably the most common small intestine cause of malabsorption in the Western world is celiac disease, and we call that celiac sprue. So although many things can cause malabsorption, celiac is probably the most common. So let's talk about celiac disease. Celiac sprue, also known as gluten-sensitive enteropathy. It's a chronic autoimmune disease of the small intestine. Now, this is not the same as gluten intolerance. So a lot of people with gluten intolerance do not have celiac disease. And we'll talk about that here shortly. But this is an actual immune response as a result of gluten, and it can be life-threatening. So it's specifically in gluten, there is a water insoluble fraction called gliadin. So it's specifically an immune reaction to gliadin. Gluten is found, it's a protein complex found in the wheat crops. So the wheat family, so wheat, barley, triticale, rye, also spelt, semolina, durum. Now oats technically is not in the same family, it's a different family, but some people do cross-react to some of the protein complexes in oats. The other thing is a lot of oats is processed in factories that process these same grains, so there's contamination. And so it's hard sometimes to separate those. What ends up happening in a nutshell is the chronic inflammatory process that sets up in the small intestine causes complete atrophy of the villi, and that results in malabsorption. So here we have a normal cross-section of a small intestine with the villi, with all of that good surface area for absorption. There's the lymph lacteals in here and the capillaries. Celiac, it's gone. Now there's different stages. So this is showing us the severe stage of celiac. And there you're going to have massive malabsorption. Usually patients with celiac have other autoimmune conditions like type 1 diabetes, Hashimoto thyroiditis, which is the most common form of hypothyroidism in the U.S., something called primary biliary cholangitis, the immune system attacks the bile ducts, microscopic colitis, which is going to be in the large intestine, going to have kind of a low-grade ulcerative colitis picture. We'll talk about that later. Psoriasis, vitiligo, and autoimmune hepatitis would be some examples of other autoimmune disease associated with celiac. Higher in patients with both Down syndrome and Turner syndromes, also to keep in mind. The presentation is going to vary, and the age of onset varies, but usually occurs in infants during the time of serial introduction. Now, there's a new theory that, and I'll talk about the pathophysiology here, that it's not just the gliadin, it's now other factors like the gliadin with things like Roundup is a pesticide, ground nut herbicide, and when the Roundup combines with the gliadin, it forms a more anthogenic compound, and so people are now developing the idea as more in adulthood, not just childhood. But typically it's been in childhood, and in mild cases we see maybe specific vitamin deficiencies and diarrhea. But in the severe cases, like in this one with the complete villus atrophy, you see chronic diarrhea, steatorrhea, weight loss, all your vitamin deficiencies, mineral deficiencies, severe anemia of both iron and B12, osteopenia, osteoporosis from calcium vitamin D deficiency, failure to thrive, growth retardation in children, a very interesting skin rash called dermatitis herpetiformis, and I think I have a picture here. It looks like herpes infection on the skin. So I've seen a couple patients come in thinking they had herpes, and actually when we went through their history, they had all this GI issue, and they actually turned out having celiac disease, and the dermatitis herpetiformis was from that. Neurological manifestations like peripheral neuropathy, ataxia, which is a gait disturbance, and depression all can be found with celiac. Frequent miscarriages, and then a small spleen. It's called hyposplenism with decreased secretory IgA, so people have immune insufficiency against certain pathogens, and they have more GI infections. There is a long-term risk from the chronic inflammation in the small intestine wall of different cancers, specifically non-Hodgkin's lymphoma, small intestinal adenocarcinoma, and esophageal squamous cell cancer. So these have all been correlated, increased risk with celiac disease. So the pathophysiology is multifactorial. We think it's a combination of genetics. So you have to have a certain genetic marker, and that's either an HLA-DQ2 allele or an HLA-DQ8. This is part of your major histocompatibility complex, part of that immune recognition system. These particular receptors bind tightly to gliadin peptides, and they create more of an antigenic compound. The prolamines are needed, and those are again, these are storage proteins. They're rich in proline and glutamine. Wheat, it's gliadin. In barley, it's called hordein, and then in rye, it's saccharin, oat, avenin. These are all prolamines, so again, people have different cross-reactivity. We usually think of gliadin, but these others can be issues as well. These prolamines are actually resistant to proteases and peptidases in the gut, and especially when that Roundup is involved. So Roundup actually creates, we're creating, it's not just Roundup, I should say, we have another factor, and that is that a lot of our crops are bred now to a lot of these cereal grains to be more resistant to moisture, to fungi, to pathogens. And as a result, we actually have also made them more protein rich. So there's more protein content. They're smaller grains. They pack in more densely into a given area where they grow. But as a result, they're much harder to digest. And so we have this interesting problem of not being able to break down these prolamines with our gut, our pancreatic enzymes. And the inflammation that this sets up, the gliadin itself actually destroys the tight junctions over time between the intestinal enterocytes. Now, once past the tight junctions, these prolamines interact with what's called tissue transglutaminase. This is an enzyme found within your enterocytes. And the TTG modifies gliadin into a form that's going to directly stimulate your immune system. T cells will cross-react then with the small bowel tissue, and that damages the enterocytes, and that causes the villus atrophy. That's going to be more typical in the duodenum and the proximal jejunum. And the damage to the intestinal mucosa is going to cause mucosal inflammation, again, villus atrophy, and that results in direct malabsorption. Crypt hyperplasia, so the crypts, those deep areas with all the mucus glands, they hyperproliferate. And so you start getting more mucus lining the intestines, and you get a loss of those endocrine cells, the enteroendocrine cells. And so that results in loss of hormone stimulation like cholecystokinin to the pancreas and the gallbladder, and that might predispose a person to gallstones. So a whole set of things has to go wrong here for this to happen. So obviously if a person already has a very jumpy immune system, and we think that's the case in people that have a high sympathetic tone, very stressed, we know the immune system is very overreactive and doesn't develop tolerance to a lot of things. But if you have very poor pancreatic function to start with, then you might not get digestion at all of these prolamines, and you're going to be more reactive. So genetics alone is not enough to explain all this. You have to have all these other factors that are in place. So the clinical findings with the assessment, for celiac would be based on clinical findings. So we look at weight loss, the unexplained anemia, and the frequent diarrhea, greater than 3 loose stools a day with potential steatorrhea. Check for labs. We check the blood counts and the ferritin to rule out anemia. Look at the electrolytes, calcium liver function test. check for hypothyroidism. But then the specific for celiac would be serological testing of antibodies. And they need to be done before gluten is eliminated. In fact, you have to be on gluten for at least 6 weeks for these tests to be accurate if you have celiac. So the biggest one is called anti-tissue transglutaminase antibodies. So that TTG, the immune system makes antibodies against it, and those can be measured, and they are IgA antibodies. This is the anti-TTG IgA. Now, a lot of people over time get deficiency of IgA, and so this test won't be accurate. So then we measure the IgG. So we usually do a panel where we measure both of these. Sometimes we just measure IgA separately to see if that's being hyposecreted. The second test would be the IgA anti-endomysial antibodies, so EMA-IgA. Again, that's only going to be accurate if there's adequate IgA. Less accurate would be actually anti-gliadin antibodies, and then what's called anti-reticulin and anti-endomysial antibodies. They're not as accurate, so we usually depend on these. So when people say they're doing a celiac panel, they usually are talking about those. But the gold standard really is going to be endoscopy. And that's going to be, if we have positive serological results with the history, then we're going to order an endoscopy, gastroscopy, and it's going to, the EGD will go all the way down and be able to do a duodenal biopsy. And that's the gold standard. And we can use what's called the Marsh system to classify the extent of the mucosal damage. So if we look at the staging here, 0 is kind of the least amount of damage. We still have villi here. Stage 4 is flattening completely of villi. And then 2, we're seeing a lot of infiltration of white cells, especially in the lymph nodes. And then in the stage 2, we're seeing a lot more infiltration. Stage 3, we still have some villi, but lots of infiltration of the white cells. And then stage 4, no villi, lots of white cells. So this is the Marsh classification system. We'd also importantly need to do in celiac screening for osteoporosis and osteopenia, and that is done biomedically through something called DEXA scanning. And so that's using an X-ray scan of the femurs, the hips, sometimes ankles, to kind of tell us about bone density. Now, red flag symptoms, we want to probably refer most cases of celiac for proper sort of assessment to a gastroenterologist. If you're adjunctive care or PCP or whatever. But if there's very severe malnutrition from malabsorption, especially in children with severe nutrient deficiencies, very severe diarrhea, and then severe abdominal pain with collapse, that could be acute abdomen. This is where we would definitely need more urgent referral and investigation. Now, this treatment of celiac is fairly simple from the biomedical angle, and that is to eliminate gluten or the other prolamines and treat any nutritional deficiencies. And I would say go further, and this would be more the adjunctive care, address the overactive immune response. Most patients should be referred to the gastroenterologist and maybe a skilled dietitian as well. So therapeutic order, really we're going to jump to level 4, usually first with our referrals. They'll need to be monitored, cancer screening, etc. But here, gluten elimination, it's curative really in 90% of cases. Now with the atrophy of the villi, really up until like stage 3, maybe stage 4 in some cases, but it is thought to be reversible if you remove the offending agent. Unfortunately, when you get too far past here, we don't think it's reversible, and that's where catching this earlier is ideal. So the gluten foods, of course, would be all the triticale crops, so wheat, barley, triticale, rye, spelt, semolina, durum. Oats, again, might be cross-contaminated. We think safe grains would be corn, millet, sorghum, teff, rice, wild rice, amaranth, quinoa, and buckwheat. Buckwheat is not a wheat. It's actually in the Polygonaceae family. And then potentially from the villus atrophy and loss of the brush border, patients might develop lactose intolerance. And so dairy elimination would be the second thing there. From the salutogenic perspective, we would want to really reduce the inflammatory process. So working with stress hormones, working with the autonomic nervous system. Again, this is where acupuncture can come in to increase parasympathetic activity, supporting organ systems and support the gut lining. And these are our most common patterns in CCM. So more of a spleen, stomach chi deficiency, dampness, small intestine heat, liver invading spleen. So you differentiate that and give the appropriate herbal therapies. There are enzymes that can be given. So the specific enzyme that can digest the prolamines is DPP4. It's a protease, and this is available as a supplement. Whether or not that's effective, it's hard to say. Again, in true celiac, people need to eliminate gluten and maybe take these as an additional precaution. Amylases, remember, work with the sugars. Now, what we've seen in studies is a lot of people that think they have celiac, when you actually do the testing, they don't. But they feel they have problems with grains, and so cutting out grains, they feel better. And, a lot of times people think it's because of the gluten. Well, it turns out the kind of evidence is pointing to the fact it's actually not the proteins, the prolamines, that a lot of people with so-called gluten sensitivity have, but actually to all the starches. Again, these modern grains are genetically designed. They not through genetic engineering, but through just breeding. They've been bred to be very resistant to breakdown by moisture and light and heat and so forth. Well, the same applies to your digestive enzymes. So if you're already stressed out, everything else, you have less parasympathetic tone to your pancreas, you're going to get less digestive enzymes secreted as a result and less amylase, and you won't be able to break down those starches as well. Well, then intestinal bacteria will do that job for you, creating lots of gas and bloating. A lot of those bacteria will actually create through fermentation alcohol, and so you feel drunk a little bit. You actually absorb alcohols. So the problem is actually not because of the gluten, it's because of the starches, and that's where amylase is going to be helpful. But also any treatment that stimulates the pancreas. In fact, the herbs that treat spleen, stomach chi deficiency really increase the vagal tone, they increase pancreatic activity. So that would be an important pattern to look at there. And then supplementing any vitamins, especially the fat-soluble vitamins, B vitamins, and the minerals that might be depleted in a celiac patient. So that's kind of our general integrated treatment approach for celiac disease. Our last condition here I'll talk about is irritable bowel syndrome, IBS. This is a functional disorder of the whole GI tract. We usually think of it with the large intestine because of the change in stools, for example, but it's really chronic abdominal pain with altered bowel habits. And I'll just say from the very beginning here, if you put a scope and actually biopsy the intestinal wall in a person with irritable bowel syndrome, everything looks normal. There's no signs of inflammation. This is, again, very different than in inflammatory bowel disease, IBD, so don't get the two confused. IBS is much more common. It's much less severe in the sense that it doesn't result in true malabsorption or blood loss or anything like that. But it can definitely be very difficult for people to live with because of the chronic pain and altered bowel habits. Very common, we think up to 10-50% in the US people have IBS. Really 40% of people who meet the diagnostic criteria for IBS don't actually have a formal diagnosis, so it often goes undiagnosed. Accounts for up to 50% of all referrals to gastroenterologists, so very common there. And often we see it associated with fibromyalgia, chronic fatigue, GERD, and different psychiatric disorders like depression, anxiety. There seems to be a direct link there. These are patients that very commonly present to integrative practices, acupuncture, Chinese medicine, because they really are not helped much by the biomedical model when it comes to treating IBS. More frequent in females. There are several subtypes of IBS. It's important to kind of categorize them. And so they are IBS with diarrhea that's predominant, that's IBS-D. Constipation predominant, IBS-C. There's a mixed type. And then chronic functional abdominal pain without any change in stool habits. So that's another type, much less common than these other types. this is a functional condition, so it results in lifestyle impairment. But the important thing about IBS, especially people who have not been diagnosed previously, they need to have other disorders excluded first before we can confidently treat IBS. So newly presenting patients who have not been thoroughly worked up really should have workups to be sure they don't have IBD or another identifiable and potentially more serious bowel condition. So our classic presentation is going to be chronic abdominal pain, cramping. It's going to be variable in location. Severity can be from mild to actually severe. I've seen people with almost appendicitis-like pain, but it turns out to be IBS. Usually the common pattern is definitely worse with stress and worse with eating. So a lot of people stop eating and they'll lose weight because of that, not because it's cancer or anything, but because they're just not eating. And then increased gas and bloating. And then altered stool habits depending on the subtype, so diarrhea, constipation, or alternating between the two. And then again, maybe fibromyalgia, headaches, foul breath, nausea, depression, anxiety, or other mental health disorders. The causes are, if you go on the internet and if you just look through the research literature, they are multiple. So we have not identified the cause of IBS. Once it was thought it was all just purely psychosomatic, we now know there are actual functional changes in the gut wall. Probably the biggest area of research is looking at that IBS is an enteric nervous system problem, involves gut motility issues. So that's how I typically approach it. And again, if we think of the acupuncture as being able to actually support the enteric nervous system via the autonomics, then we have a lot we can do with that, with therapies like acupuncture, potentially herbal therapy, and so forth. The brain, of course, is tied in with that system, so we can talk about a gut-brain axis dysregulation. And if we throw the microbiome in there, we have the microbiome gut-brain axis dysregulation. Impaired bile function, just having sometimes, like with fibromyalgia, we think it's a hypersensitivity disorder where the circuits in the brain that normally turn off pain are downregulated. And so we think that in some people, there's actually nothing wrong with the gut at all. It's all about increased pain sensitivity. So that's one theory that's out there. Chronic GI infection, people have argued there's some infective agents we just haven't identified. Impaired intestinal barrier and SIBO, that's the popular one now, thinking that IBS is caused by small intestinal bacterial overgrowth. I would argue the opposite, that actually the pattern of IBS, the enteric nervous system dysfunction, causes SIBO, which is a correlate with IBS, but not a cause. And so that's going to be ongoing debate. It's always the chicken, which comes first? Is it the bug or where it grows? Probably a mixture of both. Altered gut immune function. We definitely know that, for example, the Paneth cells, remember those are located deep down in the crypts in the mucosa, and they secrete defensins and those kinds of peptides. We know those are decreased in IBS. And then we know the different triggers like stress and GI infection all can activate this. So I've seen some patients that go traveling, they get travel's diarrhea. That resolves, but then now going for months or even years, they have IBS. And, we do all this testing. There's no bugs left, no pathogens there that we need to address, but it's almost like the nervous system became hypersensitized. And that's the problem. So it needs to be addressed, in that way. So that would be some typical findings there with irritable bowel syndrome. So in terms of assessment for IBS, again, our Rome 4 diagnostic criteria are really going to be, number one, you're going to have recurrent abdominal pain at least 1 day a week in the last 3 months. Number two, it's related to 2 or more of the following, either to defecation, a change in stool frequency, or a change in the stool form or appearance. So those are the diagnostic criteria. Both 1 and 2 have to be in place to make a diagnosis of IBS. And then based on the stool type, further into IBS-D, C, etc. Again, this is the diagnosis by exclusion. So first, you need to rule out GI infections, potentially SIBO. But again, generally this is not part of the current biomedical kind of thinking, is to, except in extreme cases, to look for SIBO. But we might want to look for the history. Is there any potential of travel recently or something that might have triggered all this. Looking at lactose and fructose intolerance, food allergies are more sensitive, but the big ones would be ruling out celiac disease and inflammatory bowel disease, and that would be Crohn's and ulcerative colitis. We've already talked about celiac. We'll get to Crohn's and ulcerative colitis, and I'll talk about their workups. In Crohn's and UC, there's actual damage, just like in celiac, to the mucosa, even submucosa. Again, that's not going to be found in IBS. And then we're going to consider our red flags, and that would be onset after 50, rectal bleeding or melena, nocturnal diarrhea, progressive abdominal pain, unexplained weight loss, family history of IBD or colorectal cancer, and then having abnormal labs showing anemia, increased inflammation, that's CRP, and something called fecal calprotectin. If we see that in a stool sample, that is going to be more indicative of IBD and not IBS, and that needs a deeper level of care than IBS. So our clinical findings, really we need to record the stool consistency, frequency, if there's blood, document any weight loss, consider any other organic disease like IBD, and then look at family history, stress, medication, mood, and sleep, all of those together. There's no specific lab test for IBD. Again, this is kind of a diagnosis by exclusion, but we can look for, the typical for anemia with the CBC, thyroid function, electrolytes, TSH is your thyroid screening test. With diarrhea, we'll look for fecal calprotectin in a fecal sample or lactoferrin, as well as a stool O&P to rule out Giardia. So those are classic tests that are done with the diarrhea subtype to rule out, in this case, IBD, or in this case, infection with Giardia. Celiac disease, assuming a person is still eating gluten, the anti-TTG IgA antibodies, and then colorectal cancer screening if it's appropriate, and that starts at age 50 with a baseline colonoscopy. If no colon polyps are found, then we can wait another 10 years before the next colonoscopy. Increasingly, people don't want to get the colonoscopy, although that's still the best way to diagnose it. They're using, for example, every year one of those FIT tests to see if there's any bleeding in the GI tract, and then you'd have to go in and do a colonoscopy to see where that's coming from. With constipation, we might do an abdominal x-ray to see if there's any distension, megacolon, anything like that. And then imaging or endoscopy if other red flags are present. So that's the assessment for IBS. Treatment-wise, there's no cure. The goal is really symptom management from the biomedical perspective. And again, we might think about a referral to a GI or PCP who can focus on this is a initial workup to exclude all these other conditions. So we usually follow the therapeutic order, and that would be our step 1 therapies. Probably the biggest dietary recommendation is what's called low FODMAP diet. FODMAPs are fructose, oligosaccharides, disaccharides, etc. You can look up what FODMAP is. But these are a whole list of foods that we think if we eliminate them, it improves symptoms in IBS. There's some good research behind it. The problem with that diet is really hard for a lot of people to stick with it. And so that's kind of a battle sometimes long term. And if there's already some malabsorption and loss of nutrients and weight loss, that can actually make things even worse. Gluten elimination could be a trial, but again, it could be because of the starches, not because of gluten. This is not celiac. And then looking at other probiotic foods, maybe probiotic-rich foods, and then our classic exercise, sleep hygiene, very important, and then psychological support. From the level 2 and 3, really addressing the endocrine system, the nervous system, and our organ systems are our main approach there. And then here are classic Chinese patterns, very similar to celiac that we saw. Now I'll just run through very briefly biomedically the medications that are given. Again, this is really not an area that's well treated in the biomedical approach, and these medications are just for symptom relief only. I'll just say that one area that we see a number of patients that maybe have fibromyalgia as well, they're given tricyclic antidepressants. So amitriptyline is one. This is very good for neuropathic pain, and there's some usefulness in IBS. For SIBO, people are giving antibiotics or herbal antibiotics, for example, neem, berberine, the allium, the garlic extracts, etc., golden seal extracts. These, or rifaximin is the antibiotic. Rifaximin is interesting. It stays in the gut. It doesn't get absorbed, and so we think it doesn't have systemic effects, but definitely it's changing your gut flora, and it can wipe out the small intestinal bacterial overgrowth, but it could also wipe out some of your beneficial bugs. So I don't really think that's great for routine use, although a lot of people within the SIBO treatments are doing that. And it's really expensive too. Insurance, if it doesn't cover it, I think it's $700-800 a month, if I'm remembering, or actually for a 2-week dose of that. So it can be quite expensive. For IBSD, the typical approach is to, number one, calm the parasympathetic nervous system down with anticholinergics. So hydrocyamine, diclocyamine, or diclomamine, dicyclomine, antidiarrheals like loperamide, antispasmodics like peppermint oil, the serotonin receptor antagonists. So these are 5-HT3. This is a special type of serotonin receptor. Not commonly used, very expensive, but it's out there. And then mu opioid receptors. These are opioid receptors in the gut, and these are agonists to that, are also used more for pain reduction in IBSD. For IBSC, the typical treatments would be fiber, the osmotic laxatives like the Miralax and the magnesium, chloride channel activators, not very commonly used. This is the Mitzia, but it's out there. And then the calcitonin C agonists, and that would be the Linzess. Again, not commonly used, but those are available for the constipation type. So as you can see, there really aren't great therapies except just for symptom control from the biomedical approach. I think what I see a lot of doctors recommend is the FODMAP diet, and that's it. And some patients get better with that, many don't. So that is kind of an overview of irritable bowel syndrome, IBS, very common condition that we see in general practice, but especially in integrative practices.